So this module, we're going to be going over some case studies, and incorporating into those case studies are going to be some South Metro agency specific protocols and our Denver Metro protocols on how we'll manage these patients in our case studies. So our first case study, you are dispatched to a 70-year-old male who is unconscious. That's your dispatch information. So you respond in. Once you get on scene, you find a 72-year-old male lying on the ground. He is pulseless and apneic. There are no bystanders around. You hook them up to your monitor and you see these vital signs. You have a EKG pattern right there. You notice the patient does not have a pulse, so they have a heart rate of 0. Their SpO2 is 86% on room air. You put them on the capnography with your bag valve mask. Notice they have 28 while you are performing CPR. They are not breathing on their own. They do not have a blood pressure, and you don't obtain any type of temperature on this patient. So my question to you is, well, what do you do about this? What do you do? We already said we immediately start CPR because they are pulseless and apneic. So we're going to begin CPR. We're going to start ventilating this patient, 30 compressions to 2 ventilations until we secure an advanced airway, whether that's in ET tube via oral intubation, nasal intubation, or a surgical crike. Once we've established that, we will go to continuous compressions and continuous ventilations. So we're doing airway management, we're doing our compressions, we hook them up to the monitor and we notice this rhythm. Looking at this rhythm, what we need to decide is this VTAC or is this VFib, or is this not VTAC or not VFib? If we notice it's VTAC or VFib, we should defibrillate this patient. If it is not VTAC or VFib, we do not defibrillate this patient. Looking at that, this is not VTAC or VFib. This looks like sinus bradycardic. Interpretation, since they have no pulses, they would be in PEA with sinus bradycardia. 2 minutes go by of high quality CPR and airway management. We do a pulse and a rhythm check, and you notice these changes in our vital signs. Patient continues to not have a heart rate. They continue to not be breathing. You have an SpO2 of 85% with our CPR. We have an end tidal value of 28 with our CPR. They do not have a blood pressure, and we did not obtain a temperature on them. You notice this EKG pattern here. Looking at this EKG, we can identify this as VTAC. We notice this is VTAC because it is a wide complex and it is regular. So I know our QRS complexes are wide. We are regular R to R intervals on our QRS complexes. And I don't identify any type of P waves going on there. And this is fast. Tachycardic is greater than 100, and this rate is right about 150. So this is VTAC. What do we do about that? Well, we want to go ahead and defibrillate this patient. We will defibrillate this patient at 360 joules. That's what we're going to want to do for this patient. Here's our arrest protocol. So we've now seen a PEA and a VTAC. So let's look at the protocol and see what else we need to be doing for this patient. We obviously, for any cardiac arrest, looking at the protocol, want to start with high quality CPR and early defibrillation. So start compressions right away as soon as you recognize this patient does not have a pulse, and get them on our cardiac monitor as fast as possible. Whether you're an ALS provider, we want to manually interpret that rhythm, or if you're BLS providers, getting them on the AED as fast as possible and having the AED and do that interpretation. Those are the two most paramount things we get done first. Once we do that, we want to follow shocking and defibrillating our patient or not. So do a rhythm check right away, or a rhythm check, right away as soon as the AED tells you to, or as soon as we can visualize our patient's cardiac rhythm. If they are in VTAC or VFib, we want to shock. How much are we going to shock them with? Well, we're going to do 360 joules of electricity for our defibrillations on our patients. So that's how much we are going to be defibrillating our patient if we're manually doing so. Our AED will spin that up, and you just press the shock button if it is advised on that end. All of our patients from there can get epinephrine. So we want to give all of our cardiac arrests, whether PEA or VTAC VFib, shockable rhythms, epinephrine. We're going to give 1 milligram of epinephrine every 3 to 5 minutes. So every other cycle, up to 3 rounds. So we're going to give up to 3 rounds of epinephrine every 3 to 5 minutes for that. If they are not shockable, we still will give the epinephrine, but we just won't shock them. 2 minutes will go by here, as you see. If they are shockable, we will want to shock, and we'll continuously shock with 360 joules. That is going to be our energy level we are choosing to defibrillate our patient with based off of our protocols. If they are in that shockable rhythm still, we can start giving amiodarone. We'll initially begin with 300 milligrams of amiodarone in our shockable rhythms. If they persist, again, we can repeat that dose every 3 to 5 minutes one time with 150 milligrams. So our patient in total, if they stayed in a shockable rhythm for long enough, would be getting 450 milligrams of amiodarone during our cardiac arrest care. If they are non-shockable on down this PEA side, we'll just give the epinephrine every 3 to 5 minutes. Every 2 minutes, we're going to be doing our rhythm checks. So with those rhythm checks, really do good pulse checks to see if we have a perfusing pulse. Look at our monitor to see what rhythm they're in, if it's shockable or not shockable. And then when we do that, we want to also notice what's our patient's capnography value at. That can give us an insight to if we might have achieved ROSC during our last 2 minutes of compressions, or if maybe we have not yet achieved ROSC. So take a look at that capnography. We will continue doing this cardiac arrest until we either get ROSC or we have done 30 minutes of high quality CPR. During that 30 minutes of high quality CPR, there's some benchmarks and objectives we should be getting done. We should establish an advanced airway as soon as we reasonably can, like mentioning that intubation or surgical crike are going to be our advanced airways for us to move to continuous compressions and continuous ventilations. We want to consider our other H's and T's, consider if there are other medications we can be giving for our patients, consider sodium bicarb and calcium if our patient's coming from a dialysis center or has a history of renal failure or renal cancer, consider Narcan if we suspect this patient's arrest was caused by an opioid overdose. We can consider giving magnesium if we have been in a persistent VTAC or VFib despite giving our EPIs, despite giving all of our amiodarone, and despite shocking our patient, defibrillating them at 360 joules. Every single rhythm check, they're still in that persistent shockable rhythm. We can give magnesium. Maybe it's torsades that we just can't recognize. That might help convert this patient out of it. We want to get a point of care ultrasound in on this patient as soon as kind of reasonably appropriately, in my opinion, as an ultrasound provider, after we've done all of our initial cardiac drugs. So I've done all of my EPIs, I've done all of my amidarones if they've been shockable. We're in this like 10 to 15 minute time frame of when we've started our arrest. That's where I'll pull out that ultrasound. We want to do our ultrasound evaluation to look for any cardiac contractility with each of our pulse checks. If we see cardiac contractility, after we've done all of our initial epinephrines, we can hang an epinephrine infusion on this patient while we continue our resuscitation. So using that ultrasound to help guide that decision as well. Can add some different interventions, or it might say we don't need to give any extra additional epinephrine. It might help guide my decision and care in different directions. After 30 minutes of high quality CPR and not having any other changes, we don't have ROSC, we've gone through all of our H's and T's, there aren't any other treatments or interventions we can be performing, that would be a time frame for us to begin thinking about a termination of resuscitation for this medical cardiac arrest patient. We also will stop our cardiac arrest anytime we get ROSC. So if we're doing high quality CPR, we're doing everything, we're giving our patient the best chance that they have, hopefully we end up getting ROSC in the field. If we get ROSC in the field, we might see some vital signs look like this. So we've been doing our high quality CPR, we do our next rhythm check, and you notice this. You look at our monitor and we see this patient was in a shockable rhythm, you shocked them, and now we end up ultimately having a perfusing rhythm. We see a heart rate of about 60. Their SpO2 is increased to 92. Their capnography end tidal had a really big spike up to 64 with that CPR going on. So really big spikes in our capnography let us know, I think we might have our patient having a perfusing pulse. They've picked up all that carbon dioxide that's just been sitting stagnant and is now circulating around to offload it off. That's picking up there. We're breathing for our patient still. And we get a blood pressure on this patient now. So now we have a perfusing pulse and we want to obtain a blood pressure. You get a blood pressure of 80 over palp is what we get here. 80 over palp. This lets us know, great, we can feel good, we got ROSC, and now we have an even more complex, challenging patient to manage and treat and ultimately transport here. So what are we gonna do about this for this patient? Right, we have our ROSC. First things we wanna do is take a good deep breath, calm ourselves down, and check some of our initial boxes we do with all of our other patients that we don't do with our arrest. Like get in our first baseline set of vital signs. We want to obtain a good heart rate for this patient, see if they are breathing on their own or not, get an intrinsic respiratory rate for this patient, obtain a blood pressure for this patient. Blood pressure is going to be really important because that might direct if I do fluid management or if I use vasopressors to try to increase their blood pressure. I also want to use that heart rate along with that blood pressure to make decisions on, is the heart rate going really, really fast and it's a cardiac problem we need to manage? Is it going really slow and is it an arrhythmia that we need to manage? So we want to do that. We also want to obtain a 12-lead EKG on this patient. I want to take a good look at their heart because that could let me know why they went into cardiac arrest in the first place. We have a fresh patient that we need to end up assessing and treating and managing. We do a 12-lead EKG on our patient, and this is the 12-lead that you get here. Things I'm noticing a somewhat slow rhythm. I have a rate at 2, 3, 4. Somewhere between 40 and 55, so we have a bradycardic rhythm, so it's slow. I notice ST segment elevation in leads 2, leads 3, and AVF. And I'm seeing reciprocal depression in leads 1 and AVL. So to me, this looks like this patient's having an inferior wall MI, which they very much so might be having an inferior wall MI. What I don't want to do is I want to reference my STEMI alert criteria. And here at South Metro, we don't want to activate a STEMI alert on any patient post-ROSC. Why do I have ST segment elevation? Well, it could be because their heart was dying because they were dead for however long that arrest was going on for. So we might have false elevation because of them being dead, not because they were dead from an infarct. It could be some other pathology that caused their arrest. But I want to note that. And if you think that this is a cardiac cause and you think this person is having an MI, have that conversation over the phone with the nurses that you're transporting to. Call and consult with the physician and have them guide your decision on if they should activate the cath lab or not. So still advocate for your patient if you think that that is the trend. We just won't activate a STEMI alert on any of our post-ROSC patients that you see elevation in. But 12-lead is really important. This patient being bradycardic might make us say we need to pace this patient. If they are hypotensive and bradycardic, we would want to start pacing this patient. We will pace our patients at 80 milliamps at a rate of 80. Then we can increase that until we obtain mechanical capture or until we max out at 200 milliamps. That would be our highest dose there. You should get it, if you don't have it at 80, right around 100 milliamps. We can confirm our mechanical capture or electrical capture with mechanical capture by palpating good femoral pulses. And this is where we can also use that ultrasound to do a point-of-care ultrasound to confirm mechanical capture on ultrasound for this patient. Post-arrest care is going to be maintaining and keeping that airway intact, ABCs, making sure they don't re-arrest, giving them blood pressure support, whether that be via fluid, whether that be via vasopressors, which would be an epinephrine infusion here at South Metro, or if that is pacing that patient, increasing their rate to potentially increase their blood pressure, depending on what your patient's situation is. Those would be things we would want to do there. We want to transport our patient emergently to the closest receiving facility. We want to try to keep our patient warm and continue to identify and address causes of their arrest and prevent those from reoccurring. That is a cardiac arrest. Our next case study we'll move into. We have a 46-year-old female who has chest tightness that's been going on for about 30 minutes. That's what you're dispatched to. Looking at our chest pain protocol here, big things we want to identify is, does our patient have signs or symptoms consistent with ACS, acute coronary syndrome? Do we think our patient's having a heart attack? That's what we're trying to identify. If our patient has some of those symptoms, which could be like crushing substernal chest pain, chest pressure, could radiate to the arm, to the jaw, to the smalls of the back. Those are our classic signs or symptoms of it. Other signs could be upset stomach, GI problems, nausea, just feeling weird, something funny going on in this acute onset. Could make us think, I think this could be more of a cardiac thing. If you think this is a cardiac thing, we can give our patient some aspirin, 324 milligrams of aspirin, as long as they don't meet any of the contraindications for aspirin, would be indicated for this patient. We also want to obtain a 12-lead EKG as soon as possible in our assessment, because that can help us identify, is this patient actually having a STEMI or are they not having a STEMI? Obtain the 12-lead as quick as possible. After we obtain that 12 lead, and we decide, yes, they are having a STEMI, or if you decide, I don't think my 12 lead's not showing a STEMI, but I still believe this patient is having a myocardial infarction, we can continue on with this chest pain protocol. We can administer nitro up to 3 times for pain management for this patient, as long as they don't meet any of the contraindications and we're able to supplement their blood pressure or protect their blood pressure if we were to have a decrease in that blood pressure. We can consider other pain medications, so any opioid pain medication we can give. I think fentanyl is our option at the moment with South Metro, so we can give our patients some fentanyl to try to help reduce their pain. That pain will hopefully reduce their heart rate and will help decrease kind of the tissue death that we've got going on for our patient. So pain management is really important. We want to, as soon as we recognize that our patient is having a STEMI, this is the only main alert at South Metro that we want to notify dispatch for. So as soon as you recognize that, have your officer, have your partner, have yourself notify dispatch that you have a STEMI alert. STEMI alerts start from the time of recognition to getting that perfusion going on there. So as soon as we recognize it, have dispatch be notified of that. Transport this patient to the closest capable facility for cardiac catheterization, so a place with the cath lab. We want to go emergently, start at least 1, if not 2, large bore IVs to be able to support them if we need to do some type of vascular support on the way to the emergency room. Make sure they've got that aspirin, and activate that STEMI alert for that receiving facility so we can get them to the cath lab as soon as possible. And that will be a case study with our chest pain protocol. Our next case study will move into this patient. We have a 46-year-old female who's walking on the sidewalk with some luggage. The patient states that she's got some heart issues and states that she's been shocked before. Patient states, I feel funny in my chest. That's their big complaint you see there. We want to go ahead and obtain an initial set of vitals, place our patient on our cardiac monitor. You notice their heart rate is 230. Their oxygen saturation is 89% on room air. We have a capnography of 42 with the normal waveform. They're breathing slightly fast at 28. You get a blood pressure of 90/58. And your cardiac rhythm shows this. We have this narrow, complex, regular tachycardia. This patient's in SVT is what I would identify that at. The decision we need to make is, okay, their rate is fast and they have some chest complaints. I think those complaints are originating from their very, very fast heart rate. Going 230 times is fast. It's faster than just compensatory sinus tach. Anything over like 160 really is when we start getting out of that compensatory sinus tach realm and into some other narrow complex tachycardia. We need to decide, are they stable or are they unstable? So do I have unstable signs, altered mental status, low blood pressure, signs of hypoperfusion or not? If we see signs of hypoperfusion, we can go immediately to electrical therapy. If we're not showing signs of hypoperfusion, we're going to want to try initially with some pharmacologic interventions. We get a 12-lead EKG on this patient, and you see this, which just further supports my decision that this patient is in SVT. If we decide that this patient is hypoperfused and we want to go to electrical cardioversion, we can synchronize cardiovert this patient at 200 joules. So we want to make sure we synchronize on our cardiac monitor so we don't create an R on T phenomenon. And we will use 200 joules for this patient. We'll advise our patient of what we're about to do. We'll perform our synchronized cardioversion. And then we can repeat that until we cardiovert. If we decide that this is not showing signs of hypoperfusion, but is something we need to correct, we'll be using a pharmacological approach initially, which will be adenosine for our narrow complex irregular tachycardias. And we're going to start with 12 milligrams, and then we can repeat that again with another 12 milligrams if they don't convert with that. After so, we still want to do all of our other treatments. We've already established IV access if we've been given a pharmacologic approach. With our adenosine, we want to make sure we have as large of a bore IV as possible, as high up on our patient's body as possible, just because that medication has such a short half-life. We want to try to get it in and perfused as fast as possible to try to get that heart to convert. So those are the two goals we're striving for when we're obtaining our IV access. We want to get IV access on all of these patients. We might need to consider vascular support if we need to give them fluid to try to increase that blood pressure and keep that up while we're attempting all of our other interventions for this patient. We're going to want to rapidly transport this patient to the emergency room. After we have converted this patient, whether it was with meds or with electricity, we see these vital signs here. Their heart rate is now 120, so still a tachycardic rhythm, but I'm noticing this is a sinus tachycardia because I see P waves in front of each QRS complex, which I didn't see before, and it is still regular. Our SpO2 has increased. Our capnography has stayed about the same. The respiratory rate has increased a little bit, but that SpO2 has come up, which is nice. And our blood pressure has come up a little bit. However, it's still a little low, 92/64. So I might want to move into some fluid boluses to try to increase that blood pressure a little bit, or monitor that to make sure the MAP doesn't decrease too much, where I would need to give some more fluid. That wraps up our tachycardic with poor perfusion protocol. Our next case study we'll talk about will be a 56-year-old male who's feeling lightheaded. You're dispatched to a nursing facility for this patient. On scene, you find a 66-year-old male in the room at the nursing facility, and the nurse is on scene. The nurse lets you know that the patient has just been feeling weak and tired, and they've been noticing that they have a low heart rate. You get a set of vitals for yourselves, and you see a heart rate of 52. Their SpO2 is 89% on room air. End-tidal is 36 with a normal waveform. They're breathing at 18 times a minute, and their blood pressure is 82/54. 82/54. You obtain a 12-lead EKG, and you see this EKG on your patient. You notice this patient has a regular rhythm and is in sinus bradycardia. A rate is going quite slow. So we need to decide, well, what are we going to do about that? Let's take a look at our bradycardic with poor perfusion protocol. And that's the big thing. We need to decide, are they have poor perfusion or not? Is my patient hypoperfused? If they're hypoperfused, we still want to try some medications, but electrical therapy is going to be the most likely therapy and treatment we're going to need for this patient. If they aren't necessarily poorly perfused and they have an okay blood pressure, they're not altered, but they still have that low heart rate, we can consider giving medications to speed that heart up. But we'd want to do that after consulting with a doctor to make sure that we don't want to overly increase their heart rate. Looking at this poor perfusion protocol, if we decide we are going to go ahead and treat this patient, we can start with some atropine for this patient. 1 milligram of atropine is going to be our initial dose for our patient, and we can increase that if we needed to. If that isn't being effective, we are going to go ahead and start pacing this patient. We'll use our cardiac monitor to pace this patient. Here at South Metro, we want to use anterior-posterior pad placement for pacing our patient. We're going to start at 80 beats per minute and 80 milliamps. And we can increase that up to 200 milliamps until we've obtained both electric and mechanical capture. Probably don't need to go to 200, likely going to get your capture at 100 milliamps, but we can increase that around there, but we can increase up to 200 if needed. After we see mechanical capture with pacer spikes in front of every QRS complex going at a rate of 80, we want that mechanical capture, confirm it with femoral pulses, and this is a great opportunity to get the ultrasound out and confirm with POCUS as well, looking for good cardiac contractility matching all of those pacer spikes. After we do all of that, we would want to reassess our patient's vital signs, make sure that blood pressure has increased. That's the big goal there. Make sure they have enough vascular support to get them to the hospital. We'll want to transport that patient to the closest appropriate receiving facility. And when we move our patient from our stretcher, our bed, our equipment to their equipment, this is a time where we need to take a little tactical pause once we get in the emergency room. There could be a lot of people, a lot of commotion going on, and we need to have a really nice conversation with staff and that we're all on the same page when we move our patient and get them off of our cardiac monitor pacing them and onto their cardiac machines pacing the patient. This is a chance that we might remove our patient from our pacer too early, and then it might be challenging to regain that mechanical capture, and it might not ever happen again. So we want to make sure that both us and the receiving facility are prepared before we turn our pacemaker off, and make sure the receiving facility is prepared to pace that patient. That will wrap up our bradycardic rhythms with poor perfusion protocol.